There is a conversation that happens in hospitals every single day that I believe is one of the most consequential failures in modern medicine. A patient over 65 sits across from a surgeon. The surgeon presents a recommendation. The patient, trusting the white coat and the credentials on the wall, nods. The consent form appears, and somewhere in that room, the questions that should have been asked weren't. Not because the surgeon is a bad person, not because the patient is naive, but because the system was never designed to slow down long enough for the conversation that aging bodies genuinely require before a major operation. I have been on both sides of that table. My name is Dr. William Lee, and I am a cardiothoracic surgeon with 29 years of experience in the operating theater. I have performed operations that gave people decades they would not otherwise have had. I have also stood at bedsides after procedures and thought, if someone had asked the right questions beforehand, we might not be here. Today, I am going to make sure you have those questions and the understanding behind them before you ever need them. Let me be direct about what this video is and what it is not. This is not an argument against surgery. Surgery is one of the most extraordinary tools in medicine, and I have dedicated my career to it. This is an argument for informed consent, real informed consent, the kind that includes an honest conversation about what a specific operation costs a body that has been living for 7 or 8 decades, and what alternatives exist that most patients are never offered. Here is the foundation that makes everything else matter. When an older body goes under general anesthesia, it is not the same physiological event as when a younger body does. The heart works harder to maintain output under anesthetic agents. The lungs take significantly longer to clear those agents after the procedure. The kidneys, operating at reduced efficiency, process postoperative medications more slowly and less completely. And the brain, this is the one that most patients are genuinely never warned about, can become profoundly disoriented in the days and weeks following major surgery in ways that, in some older patients, never fully resolve. This is called postoperative cognitive dysfunction, and its incidence in patients over 70 is substantially higher than the preoperative conversations most surgeons have would suggest. There is also a clinical concept that every person over 60 deserves to understand before signing any surgical consent form. That concept is frailty. Not age, frailty. Frailty is a measurable medical state defined by the depletion of physiological reserve below a critical threshold. It is not about how many years you have lived. It is about how much capacity your body retains to absorb a major physiological insult and then recover from it. Research consistently shows that approximately 40% of adults over 75 meet clinical criteria for frailty, rising towards 60% over 85. And the question that matters most before any major operation is not whether the patient can survive the surgery, it is whether they can survive the recovery. Those are different questions. The answer to the second one is what determines outcomes. Surgery number 1, open heart surgery in frail patients. Coronary artery bypass grafting is among the most frequently recommended major surgeries in older adults. The rationale is clear. Blocked coronary arteries are bypassed to restore blood flow to the heart muscle. For a physiologically fit patient in their early 60s, the procedure can be genuinely transformative. But here is what the consent discussion rarely conveys with adequate clarity. This operation requires the heart to be stopped completely for its duration. A cardiopulmonary bypass machine takes over the combined function of the heart and lungs while the surgeon works. For a body with strong organ reserve, this is a manageable challenge. For a 77-year-old managing early renal impairment, type 2 diabetes, and mild cognitive changes, that bypass machine represents a coordinated assault on every major organ system simultaneously. Published data on frail elderly patients undergoing open-heart surgery shows complication rates in the range of 30 to 40%, including stroke, acute kidney injury, prolonged mechanical ventilation, and postoperative confusion that can persist for months or permanently alter cognitive baseline. In the highest risk elderly group, 30-day mortality figures reach levels that most patients, if told plainly, would find profoundly affecting. What many patients are never told is that catheter-based alternatives, procedures that achieve comparable cardiac outcomes without stopping the heart or opening the chest, are now available at most major cardiac centers. The question worth asking your surgeon before agreeing to open heart surgery is simply this: Is there a catheter-based or minimally invasive option appropriate for my profile? That question, asked calmly and directly, has changed the surgical pathway for many of my patients. Surgery number 2, aggressive spinal surgery. Back pain after 60 is so prevalent that it has acquired a kind of cultural inevitability, something to be managed, endured, and eventually perhaps fixed surgically. And increasingly, the fix being recommended is structural: spinal fusion, multi-level decompression, the permanent implantation of metal hardware along the vertebral column. I want to be precise here because some spinal surgery is not just appropriate but urgent. Progressive neurological deficit, loss of bowel or bladder control, evidence of active spinal cord compression. These require prompt surgical evaluation. That is not the surgery I am discussing. I am discussing elective fusion for chronic degenerative back pain, and the outcomes data on that specific intervention in elderly patients is, to use a clinical term, uncomfortable. Large-scale analyses have found complication rates exceeding 40% in patients over 65 undergoing complex spinal fusion. The complications are not mild. Deep vein thrombosis, wound infection, instrumentation failure, and adjacent segment disease, the progressive deterioration of the vertebrae immediately neighboring the fused section, because the mechanical load of the spine has been permanently redistributed, all feature prominently. What troubles me most is not the complication profile alone. It is the efficacy data. High-quality research comparing aggressive spinal fusion to structured conservative management, targeted physiotherapy, pain management, guided injections, has found no meaningful advantage in long-term pain relief for the surgical group in many elderly patient profiles. Equivalent outcomes, dramatically higher risk. A colleague whose surgical judgment I have respected for many years once said to me that the most important operation a surgeon performs is sometimes the one they decide not to perform. I have thought about that observation many times since. Surgery number 3, major cancer resections in elderly patients. This is the most emotionally complex surgery on this list, and I approach it with the care that complexity deserves. When a person receives a cancer diagnosis, the instinct toward decisive action is not just understandable, it is human. I have felt it myself when people I care about have received that news. But 3 decades in surgery have taught me something that must override instinct in certain clinical situations. The purpose of cancer treatment is not to remove a tumor. The purpose is to give that person more meaningful life. And in some cases, in frail elderly patients, major surgical resection accomplishes the first goal while working directly against the second. Consider the Whipple procedure for pancreatic cancer. It involves removing the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the biliary tree. Operating time runs 6 to 10 hours. In a physiologically robust patient, it can extend life meaningfully. In a patient in their early 80s with significant cardiac and renal compromise, the procedure may be technically successful, pathologically clean margins, tumor removed, and the patient may still not survive the month. Not from the cancer, from the cumulative physiological cost of the operation itself. This is what the surgical literature calls futile intervention, and it is more common than the profession openly discusses. A landmark analysis by the American College of Surgeons found that close to 1 in 5 elderly patients undergoing major cancer resection experienced what researchers termed failure to rescue. A serious complication developed that the depleted body could not recover from. Before agreeing to major resection, ask your oncologist directly. If we pursue non-surgical management, radiotherapy, targeted therapy, watchful monitoring, what does that pathway look like for someone with my specific age and health profile? Many patients discover, in the answer to that question, a path they did not know existed. Surgery number 4, elective joint replacement in medically complex patients. I want to say something unambiguous before anything else. Hip and knee replacement surgery for the appropriate patient at the appropriate time represents one of the most consistently successful interventions in the history of surgery. The transformation in quality of life it produces for well-selected patients is genuinely remarkable. I am not here to discourage anyone from a surgery that could meaningfully restore their mobility and independence. What I am here to say is that the word elective carries weight that deserves careful attention. Elective means planned. It means the timeline is yours. And that timeline is an opportunity to evaluate, to prepare, and to ask honestly whether your body is in the optimal condition it can be in before you proceed. Because the outcomes data on elective joint replacement in patients over 75 carrying 3 or more significant comorbidities, poorly controlled diabetes, significant cardiac disease, chronic kidney impairment, shows substantially elevated perioperative risk compared to healthier patients of the same age. Venous thromboembolism is the most serious concern. Blood clots forming in the deep leg veins can travel to the lungs with life-threatening consequences, and this risk is meaningfully amplified in elderly patients with already compromised peripheral circulation. Postoperative pneumonia from prolonged immobility and hospital-acquired infection add additional complexity to an already challenging recovery equation for the medically vulnerable. The question is not whether to ever have joint replacement. The question is whether this is the right moment for your specific body, and whether a formal prehabilitation program optimizing your cardiovascular fitness, blood glucose control, and nutritional status before the operation has been offered and undertaken. Some surgical centers now require this for high-risk elderly patients. Ask your surgical team about it directly. Most patients have never heard the word prehabilitation. Every patient considering elective surgery should. Surgery number 5, emergency abdominal surgery. This surgery stands apart from the others because you do not schedule it. It arrives without warning and without the luxury of considered decision-making. A perforated viscus, acute intestinal obstruction, uncontrolled internal hemorrhage. These are situations that demand immediate response. But the reason this surgery belongs on this list is precisely that reason. Understanding its risks before an emergency occurs changes the quality of the decisions made by families in the moments when there is no time to think. Emergency abdominal surgery in patients over 75 carries mortality rates that in the most severe presentations range from 30 to 50%. Not because surgical skill is inadequate, because an elderly body confronted with sudden major trauma is managing simultaneous physiological crises across multiple organ systems. The inflammatory cascade that a younger body can contain and resolve within days can, in an older body with reduced reserve, escalate into systemic inflammatory response syndrome, the sequential failure of organ systems that is precisely as serious as it sounds. 2 things you can do with this knowledge right now. First, take abdominal symptoms seriously. Persistent, unexplained pain, significant changes in bowel habits, recurrent bloating that does not resolve. These warrant prompt medical evaluation in anyone over 60. Problems identified early are managed electively. Problems ignored become emergencies. That distinction is often the difference between a planned procedure with adequate preparation and a desperate intervention at 3 in the morning. Second, have the advanced care conversation with your family now. Not in a hospital corridor under fluorescent lights with a surgeon nobody in the room has met before. Now. What are your wishes if emergency surgery becomes the only option? What does quality of life mean to you? These conversations are among the most genuinely loving acts available to you, and they cost nothing except the willingness to have them. Before any major planned surgery, there are 4 questions every patient over 60 should ask and receive a specific, honest answer to. What happens if I do not have this operation? A surgeon who is right for you will answer this honestly. If nothing critical changes over the coming months, you have time for reflection, for a second opinion, for optimizing your health. Is there a less invasive alternative? The surgical landscape has been transformed over the past 15 years by robotic-assisted techniques, endoscopic approaches, and catheter-based interventions. Alternatives that did not exist when your parents were your age are now standard at most major centers. What does recovery realistically look like for someone with my specific health profile? Not the average patient, but me. The answer should be detailed and individual, not generic. And finally, the question most people never think to ask: what is your personal complication rate for this procedure in patients over 70? Surgeons know their numbers. A surgeon you can trust will share them without discomfort. If that question produces evasion rather than a clear answer, that itself is information worth having. I want to leave you with a patient I will call Amir. He was 74, a retired architect from Glasgow, meticulous and precise in the way that people who have spent careers thinking about structure tend to be. 4 different surgeons had recommended coronary bypass surgery for a significant arterial blockage. 4 consultations, 4 identical conclusions. Amir was not afraid of the operation itself. He was afraid of what he had seen it do to people he loved, the cognitive fog that settled over his closest friend after cardiac surgery and never fully lifted. The man who came back from the hospital technically alive, but somehow less present in the world. When I reviewed Amir's complete profile, his renal function, his frailty assessment, his cognitive reserve, his own values, and what he wanted his life to look like, I gave him an unhurried conversation. I told him the truth. Surgery was a legitimate path. So was an intensive, carefully monitored medical management program with structured cardiac rehabilitation. For his specific clinical profile, the published evidence showed comparable outcomes over a 5-year horizon between the 2 approaches. He chose not to have surgery. That was 3 years ago. He sent me a photograph last spring. He was standing outside a building he had designed 30 years earlier, recently restored, with his adult children beside him. He said the building looked better than he remembered, and that he felt the same way about himself. A surgical recommendation is not a sentence. It is the opening of a conversation, one that you have every right to participate in fully, with every hard question asked, every alternative explored, and every day of consideration taken that you need. The surgeon holds the instruments. You hold the decision. That decision, made with complete information and unhurried clarity, is the most powerful act available to any patient. If this gave you questions worth asking, questions that might change a surgical decision you or someone you love is facing, please share this video. Subscribe to this channel for honest, evidence-based guidance on the medical decisions that matter most for adults over 60. And leave me a comment telling me which of these surgeries is most relevant to your situation. I read everyone personally. Your age is not a limitation. Your questions are your greatest protection.